Sir, my question is drug-induced sleep endoscopy, sir. DISE.
Okay.
Shall I start, sir?
Yeah, please go ahead.
Yes, sir. Yes. It is a diagnostic tool to assess the upper airway snorers and obstructive sleep apnea patients in conditions that mimic natural sleep. It was first introduced by Croft and Pringle in 1991. It is also known as sleep NAS endoscopy, also known as sleep endoscopy. It is an upper airway evaluation technique with three key features involving the use of pharmacological agents to achieve sedation, the target depth of sedation as approximating natural sleep as much as possible, and the endoscopic evaluation of the upper airway. Indications: patients affected by socially disturbing snoring and the obstructive sleep apnea hypopnea syndrome in whom non-CPAP therapy is considered. Second one, failed CPAP therapy or difficulty in tolerating CPAP therapy, and in patients in whom previous surgery has failed.
Very good.
It should be performed in safe clinical settings such as operating room, endoscopy room, and clinical room, which sets up with standard anesthetic equipment like basic monitoring and resuscitation kits in case of emergency. And sedative agents which used for DISE are propofol, midazolam most commonly, and the last one is dexmedetomidine. The sedative agents will generally be administered intravenously at the minimum dose to achieve the target depth of sedation. Unconscious sedation represents a lesser degree of neural depression than anesthesia and may be a closer approximation to natural sleep. The most important evaluation of depth of sedation is clinical through the onset of snoring, disordered breathing events, and the loss of consciousness. Bispectral index BIS score may provide an additional information about monitoring of sedation, and the value needed during this DISE ranges from 50 to 70. Vote classification. I want to discuss about two types of classification in DISC, sir. And first one is vote classification. It is a DISC classification system for reporting DISC findings based on the analysis of severity and the configuration of obstruction at 4 anatomical levels: V for velum or soft palate, O for oropharynx, and T for tongue base, and E for epiglottitis. The severity of obstruction can be classified as 0 to 2. 0 which is no obstruction, 1 partial obstruction, 2 complete obstruction. Vote classification provides a clear and simple framework for robustly and accurately analyzing upper airway obstruction. And second classification is NOHL classification, which stands for N nose, O for oropharynx, and H for hypopharynx, and L for larynx. And the grades are from grade 1, which is 0 to 25% obstruction, grade 2 25 to 50% obstruction, and grade 3 50 to 75% obstruction, and grade 4 which is 75 to 100% obstruction. DISC has been extremely useful to the ENT surgeons in understanding, identifying, and possibly alleviating some of the upper airway obstruction where possible, and the role of ENT surgeons in this multidisciplinary field of sleep-related breathing disorders has been highlighted. DISC has been found to be useful for some of these treatment options in patient selection, and has also aided in identifying why some patients have failed CPAP therapy. Similarly, when surgery fails, repeated assessment of the upper airway obstruction by performing DISC may throw some light on the residual problems. Contraindications: patients, those who are not in fasting, those who are not having safe airway, those who are having significant nasal obstruction, and pregnant patients, and those who are allergic to drugs like propofol, midazolam, etc. Complications. Complications are nasal bleeding, laryngospasm, hypercapnia, desaturation and loss of the airway, and a need for intubation or a need for a surgical airway. Challenges of DISC for anesthesiologist. There will be no O2 supplements, and there will be increased risk of aspiration, and all patients done as a daycare procedure, and anticholinergics not allowed, and no Guidal survey allowed. That's all.
Okay. How long is this procedure done? This is the
15 to 20
duration
minutes.
of this procedure. Actually, it's about 15 to 30 minutes. Okay. So in this 15 to 30 minutes, what do you want to achieve? Is it only for ENT surgeons to identify the upper airway obstruction, or in any other condition. If it is a purely ENT procedure, why should we be worried about it as an anesthesiologist? Where do you use CPAP? Which condition you use?
Sir, why obstructive sleep apnea patients?
So it is one of the important diagnostic tool for obstructive sleep apnea patient also, who are not willing for CPAP initially or who do not improve with CPAP. Normally, majority of the obstructive sleep apnea patients will improve once you start treatment with CPAP during night times. Whereas patients who still find it difficult to breathe with the CPAP or do not show any marked improvement with the CPAP, they should undergo this sleep endoscopy. And the very purpose of doing it is to simulate a normal sleep pattern and try to see where exactly the obstruction is happening. That is the purpose of this drug-induced sleep endoscopy. We are inducing sleep which should mimic a normal sleep. What are the types of sleep we normally have? Any person not is a normal physiology of sleep. What are all
REM
the
and non-REM?
REM and non-REM.
Non-REM, yes.
So rapid eye movement sleep, which occurs first, which occurs later. When you go and try to sleep, whether you develop REM sleep first or non-REM sleep first.
REM first, sir.
Initially REM, then you go for non-REM. So this study, should it be done in REM sleep stage or non-REM sleep stage?
Sir, non-REM.
Non-REM sleep stage, okay. So on that achievement of non-REM sleep state is done only by using the bispectral endoscopy, okay. So another important clinical method is to identify that patient should not respond to verbal commands. These are the two important things that you have to remember, okay. So once you start giving the induction agent, whatever agent you are using like propofol or dexamethasone or ketamine, whatever you use, patient should be non-responsive to verbal commands or verbal stimuli. That is the clinical endpoint for achieving. There you should stop. And with a bispectral associated bispectral monitoring, you should aim to achieve a level of 50 to 70, which indicates a non-REM sleep pattern. And this is a dynamic tool. So as you use endoscope, is it a nasal endoscope or oral endoscope?
Nasal one, sir.
Nasal. And you choose the smallest size of endoscope, okay. So they recommend that you should not use a very large normal adult size endoscope. You can go for even a pediatric scope, and it should be need not use any topical also. You no doubt have to spray with 4% or 10% lignocaine. So no topical spray is required, no decongestant is required, and no antisyllagogue is required. These are all the three things that you have to remember. And there should be a suction port available, because once you start inducing the patient and doing the scopy, after 10 to 15 minutes of scopy inspection, there is bound to be increased salivation and secretions, which should be cleared by a suctioning port. And you continue that. And as you rightly said, the vote classification tells where exactly start inspecting from the choana, that is from the nasal cavity. And then go to the soft palate, that is the velum, then go to the oropharynx, then go to the tongue base, then go to the epiglottis. All these levels you can see, and report that. At the end of that, you can do a video recording of this also, so that it can be used to explain to the patient where exactly his problem is happening, and that you can use it in case later on when the surgeon wants to do some procedure. This can be seen and locate the level of block or obstruction, and then that can be attended to that. So these are the few points I think you can add to your answer. Otherwise, you have done a good job. Shall I go for another presentation?
Thank you, sir.
Screen visible? Is it visible now?
Yes, sir.
Yes, sir.
Yes.
Okay. The drug-induced sleep endoscopy is a diagnostic tool. Correctly, you mentioned the definition to assess the upper airway, snorers, and obstructive sleep apnea patients in conditions that mimic natural sleep. This is the full definition of Dise. The diagnostic tool to assess the upper airway of snorers and OSA patients in conditions that mimic natural sleep. Okay? It is of utmost importance to understand the upper airway behavior during sleep so that a tailor-made treatment can be decided for every patient. And the observation of upper airway during natural sleep is complicated. That is, when we do overnight polysomnography, we are taking all indirect parameters. Like we take this noise sound, we take the pulse oximetry, hypoxemia, we see the EEG, we take the EMG for the jaw muscles, we are monitoring the X-ray, ECG, abdominal muscle tone. All these things are all indirect methods of finding out the degree of obstruction. Whereas by doing a Dise, we are able to pinpoint and locate where exactly the problem is. And with the aid of sedation, upper airway obstruction can be observed dynamically. This is a very, very important because in overnight polysomnography, we do not do any endoscopy. So we are just making a guess where will be the obstruction. Either it is a pharyngeal muscle or a big tongue or a tonsil, all these things, we are just making a guess only. Whereas by doing a DISC, we are able to observe dynamically, allow the sleep surgeon to have an accurate idea of what is happening during sleep and possible treatment options. And it's critical to achieve a sedation level that resembles natural sleep in order to obtain the reliable DISC findings. And the safety of the patient is important when you do that. So the room should have oxygen supply and they should be able to correct any hypoxemia that is likely to happen by inducing artificial sleep in these patients. And another important thing is the room should be quiet and dark. You can't do it in a very well lit theater or endoscopy room. So the conditions should also be suitable for normal sleep. And in order to perform DIC, a patient must be monitored with electrocardiogram and pulse oximetry, just as you do in a overnight polysomnography. And monitoring the depth of anesthesia, you use a BIS monitor and use a value between 70 to 50 to evaluate the adults. And evaluation of the upper airway in a lighter sedation may underestimate the obstruction. So it has to be done at the correct plane or correct sleep stage. Whereas a deeper sedation may cause artificial obstruction to over sedation. And for children, this is not applicable because these values do not correlate properly within children. And the thinnest possible fiber endoscope, ideally with a working channel to aspirate secretions, is recommended. A recording system of video and sound, if possible, is ideal. The videos can be replayed to the patient to help them understand their problem better as well as potential difficulty in addressing the obstruction, and useful in future for surgeons to use it if any surgery is planned. And for inducing sleep, you can use midazolam, propofol, dexmed, remifentanil, ketamine. All these things have been used. But the propofol with the TCI is supposed to be the best one. So I'll tell you about that. So propofol using target control pump provides a better control. And comparing natural sleep and TCI propofol sleep have shown that critical closing pressure, that is the pressure where the upper airway gets closed and the pressure generated by that, and upper airway muscle responsiveness, apnea hypopnea index, levels of sedation as measured by BAS, and site of obstruction are all equivalent to N2 and N3 stage of sleep, that is non-REM stages of sleep. So this natural sleep and propofol induced TCI propofol sleep is almost similar and you get the best results out of that. REM sleep cannot be reproduced by propofol sedation, and DISC usually takes only about 15 to 30 minutes. Within this short time, only N2 sleep can be achieved. And it is during this stage that most of the events occur, unless the patient has event only in REM sleep. In some patients, it can happen in REM sleep also. And DISC should be considered as a snapshot of what happens during night, but it cannot provide the information for the entire night. And titrate the TCI propofol pump slowly to achieve the level of sedation to achieve a BIS score of 70 to 50. And you can program the pump in such a way that you start with 2.2 2.5 ml microgram per ml, and then increase it to 0.5 ml every 2 minutes until the level of sedation is achieved. So you start with a lower dose, gradually increase it until you get a BIS value of 78 to 50. And sometimes if you find there is a short of time, you can add 1 or 2 milligrams of midazolam at the beginning. It will shorten the time of observation window, but it may also cause increase in sneezing and make the assessment more difficult. That is one drawback with that. And Dise is not painful, so local anesthesia of the nose is not necessary. Nasal decongestion solutions are also not required. And patients are usually observed in the supine decubitus position. But in some patients who are used to sleeping in the lateral position because they get obstructed if they lie supine, you can do the same thing in the lateral position also. Assessment of upper airway in lateral position does give additional information, especially for those patients who sleep mostly in lateral position. And it's very common for patients to open their mouths during the DAC as they usually do at home. If the mouth is open, the tongue may move back and pushing the soft palate and further obstructing the upper airway. So changes to these areas and pattern of obstruction can be observed by just closing the mouth. So instead of keeping the mouth open, you can just manually close it so that you can find whether there is any obstruction at the soft palate or the pharyngeal level. This maneuver, often called the chin lift, is different from Eschmark maneuver, which is gently pulling the jaw forward to stimulate which is called the mandibular advancement device. So this is how that has to be done. You can see the patient's jaw is being pulled by the operator. He is holding the lower jaw both from inside and outside. Can you see the two fingers? This is the index finger, this is the thumb. So he is holding the entire mandible and pulling it forward, and there is the BIS monitor attached. The electrode sensors are attached here. So even as the induction is being done, the jaw is falling back and that is being pulled. This is called the Eschmark maneuver. And after that, they pass the endoscopy through this. So it is better to begin the observation at the upper part of the airway, just below the choana, in order to see the palate and how it closes. Sometimes there may be tongue base or epiglottis collapse while the palate is still open. Most of the time, it is impossible to see the tongue base and epiglottis as the soft palate is closed. After observing soft palate for 1 or 2 minutes, the scope can be advanced downward to observe the rest of the upper airway. After observing every level, we can proceed with the maneuvers, and Dise should take approximately 15 to 30 minutes time. Longer observation not useful as the UA will be full of saliva due to the inhibition of deglutition by propofol. Okay, so that is why it is kept very short. And the events that must be observed are the areas of vibration and collapse as well as the shapes of the collapse. For proper assessment of the shapes and obstruction, the tip of the endoscope should be in the middle of the upper airway. So these are all the pictures which show the various levels starting from the nose as you go in. This is how each level. So A, B, C, you can see the D, E, F. This is the base of the tongue, looking like a book being opened. And this is a little lower down. This is the epiglottis. So all these levels are being seen here. So examples of complete collapse observed at different areas. A is the velum, that is the soft palate, anteroposterior. This is A, the lateral position, and A circular. So this is how the three shapes can be there. The soft palate level, it can be an AP collapse, or it can be a lateral collapse, or it can be a circular collapse. And the oropharynx level is the D. and E is the tongue base, anteroposterior due to lymphoid hypertrophy. And G is the tongue base, concentric, and AP diameter. H is epiglottis, and H epiglottis in the lateral position. So these are all the things which just for an idea how they can look when you do the scopy, because you can't write all these things in the exam. And indications and contraindications, the patient is unable to tolerate CPAP. I think Mutmani mentioned all those things. And Dise can also be performed when you to understand the reason for CPAP failure. And these are all the modified vote classification. And contraindications include American ASA4 patients. Of course, nobody will like to take up such patients for this, pregnancy and allergy to drugs. And even if the patient's apnea-hypopnea index is very high, that is not a contraindication. So if you have done a polysomnography earlier and you are not able to find out the cause and the AHI is very high, you can still do a drug-induced endoscopy. That's not a contraindication. And once you have completed that, you report the level of sedation and the lowest oxygen saturation. That this is how the report should be given to the patient. What is the level of sedation you achieved by this scoring clinically, and lowest oxygen saturation observed during the procedure, and what are all the drugs used and there's the dosage, and upper airway findings, at what level you found the obstruction, and what maneuvers were required or done during this. All these things should be written in the report, and that will be the complete thing to indicate. Okay.
Actually,
Okay, sir.
we learned. I'm
any
sure.
other
I'm sure the
questions?
students would have learned a lot from this. The thing is, this is quite demanding. Whatever they're doing when you want to mimic a normal sleep, but do it with the help of a drug, it's quite demanding on the part of the anesthetist. But when we want to do these things, we must have the pump, the infusion pump. We must have the BIS. Without those monitoring, do not venture to do just a sedation for these patients. That is not what we are talking about.
Don't
when we are
take it
talking about
lightly.
this procedure.
Ultimately,
Yes.
don't take it lightly or get pressurized by the ENT surgeon or other people just to give
We
some
need to have
propofol
the
and
pump.
finish
Yes.
it off. Don't take it for granted. Be always ready
Yes,
to face any crisis, especially obesity, OSA patients. You should be doubly careful.
Yes, sir. Very demanding, sir. ஒரே ஒரு தடவை போயிட்டு really very difficult, sir.
Okay.
Thank you, sir. Thank
Any
you, madam.
question?
Any questions from the students? If no question, we'll move on to the next topic, sir.
Okay.